Welcome back to MSK2. We're finishing up our journey through the body with the temporomandibular joint and temporomandibular disorders. I want to talk with you about a few people who have been instrumental in the development of knowledge in the area of temporomandibular disorders. The first is Mariano Roccabato, who is from Santiago, Chile. Mariano has traveled the world teaching about physical therapy. He teaches in 3 languages, Spanish, English, and Italian, and he speaks French but not well enough to teach in it. Mariano's sister is a dentist, and she asked him for a year or 2 to come to her clinic because she felt, based on what he was telling her about his learning, that he would be able to help some of her patients. And when he got to her clinic, he asked his sister what took her so long to invite him there, because he saw many things that he could help. In fact, he saw so much that it piqued his interest in growth and development of the craniofacial area and the growth and development of the TMJ. Also instrumental in our understanding of headaches and craniofacial pain is Cesar Fernandez de las Peñas, and he has been instrumental in research related to dry needling of active trigger points related to tension, headaches, as well as a lot of information about how treating the cervical spine can influence the facial pain. So let's talk about the anatomy of this area. To refresh your memory, we have the temporal bone here, and the mastoid process is actually part of the temporal bone, starting down here. And this is the posterior glenoid spine in the back, the glenoid fossa, the articular eminence, and the articular tubercle here. The articulating surface of the articular eminence is convex, and it's the primary load-bearing area for the TM joint. The trabecular bone is thicker here. It looks like that this would be a convex on a concave surface, but this is not where the TM joint is supposed to bear weight. It's held tight to this bone with a ligament, and this is where the load is intended to be directed. This articulating tubercle does not have a bony stop. It looks like there's a little spur on this specimen, but it typically just can, on certain patients, allow this mandibular condyle to just float right in front of the articulating tubercle, and that can be a significant shift in the jaw when that happens at the end of opening. So what we're looking at here is a convex on convex bony structure, and that is not a typically stable structure. Here's the mandible, and we have a U-shaped bone with condyles on either end on top. In front of this bony projection is the coronoid process. The vertical portion of the mandible is called the ramus. This angle here is the mandibular angle. The body of the mandible is here. Posteriorly, you can see that the medial pole is slightly posterior of the anterior pole of the condyle. The condyles can be different shapes side to side. They also can have different orientation. One may be 10 degrees in front of the horizontal line, and the other may be 20 degrees. So it can change the function side to side, which would change the pattern of opening. The TM joint is separated into upper and lower parts by the articular disc. So this is the articular disc, and it has two separate synovial capsules and cavities, one on the superior aspect and one on the inferior aspect. And this is where we can be of assistance to the dental professionals because we know a lot about synovial joints. We know a lot about what happens when we have a capsulitis. We know what happens when we have an intra-articular bleed and a hemarthrosis. And so we can really assist the dentist in understanding the physiology of synovial joints. The articular disc is biconcave, so I think about it as a more complicated gummy lifesaver, where we've got a thicker outer portion and a thinner central portion. The outer portion in the posterior aspect and the anterior aspect are vascularized and innervated, but the middle portion is not. Posteriorly, this is the external auditory meatus. Posteriorly, there's a bilaminar retrodiscal area, which is highly innervated and highly vascularized. It has a superior aspect that is elastic and an inferior band that's inelastic, and this helps to produce a little resistance to end range opening. You can guess that if there's pressure put on a pain-sensitive structure, that could result in problems for the patient. Go back to that disc that slide one more time. If we could look at a coronal plane, what we would see is that there's ligaments that connect the disc to the condyle, both the lateral ligament and the medial collateral ligament. So these, you can think about these like the knee ligaments that attach the disc to the condyle. So when we look at the objective exam, we've talked about a forward head posture, and we've discussed how there can be increased load at the C5 level the farther the external auditory meatus gets from the acromion. How the loading of a 12-pound head, or 12 pounds of load on the C5-6 area from a 10-pound head can increase to 32 pounds and as much as 42 pounds of load on this area. So the forward head posture plays a huge role in the temporomandibular joint disorders, because you can imagine the farther the head goes forward, the more tension and pressure there are on the infra and suprahyoids, creating a retro force on the mandible. Additionally, the patient who has open mouth breathing due to allergies or asthma, not only do they have a higher incidence of dental caries because the normal flora in the mouth has decreased, but they have a change in both the size of the tongue and the resting position for the tongue, and in the development of the mandible. Also, we're going to look at facial asymmetry during our exam in lab. So we have a change in the length-tension relationship of the muscles in the craniovertebral area. We've already talked about a posterior cranial rotation where we have a shortness of the psooccipital muscles, but what we haven't discussed yet is that there is a lengthening of the muscles in the inframandibular area, both the suprahyoids and the infrahyoids, which will make them mechanically inefficient, and we'll have a vertical SCM, which also makes that a very inefficient neck rotator. So we can see head and neck posture are intimately related to the growth and development of the temporomandibular joint, as well as the development of temporomandibular joint disorders. So the patient, this is a patient that is a very good example of forward head posture. He does look like he has his lips together, but the cranium is in posterior rotation, the SCM is vertical. Look like we have poor tone throughout, as well as poor scapular tone. It looks like we need to feed him a sandwich, I think. All right, so facial symmetry is something that we look at the right and left halves of the face, as well as the development of the thirds of the face. So in this picture, we look at the third being from the hairline to the nasium, and from the nasium to the subnasium, and from the subnasium to the mentis, or the inferior part of the chin. So we want to document this in our initial evaluation, and I am actually taking pictures of patients in a very sequential manner so that I have documentation of what they are in their initial examination, because the patient may change over the course of treatment, and you may see some of these patients for quite some time, and you want to make sure that you if there are changes, that you can document that that happened prior to you seeing the patient. So we kind of look at facial symmetry where we draw this line down, and then we look at the lines on the horizontal where the lips are at the same horizontal line, the jawbone, the nostrils, cheekbones, inner eyes, pupils, and the outer eyes, and the eyebrows. And we can even look at earlobes, although they can tend to be different spaces, but also you can look at the mastoid processes from the back. And here is an asymmetrical face where you can see that this line here is pretty good, but this eyebrow is lower. The corner of this eye compared to the corner of this eye is lower. This nostril lower than this one, and now we see starting to see a big difference in the mouth angle as well as the chin angle. So this is a face that did not develop equally on the right and left sides. And here we can see some facial asymmetry where these lines are not parallel to each other, which tells you there is a little bit more of a facial development issue than a head tilt where those lines would be parallel. So here's one of our students a few years ago that agreed to allow us to use her picture, and this is a good example of eyes that are not at the same level, and you can see on the eyebrows the same thing. She has a deep groove here which suggests tension throughout the mandible and the soft tissue, creating a retroforce. And you can even see this little groove right here is shifted off to the side a little bit. And here she shows us her forward head posture. But interesting that we can see a little bit more of her face and her eye against her nose on this level, so she may be rotated just a little bit. And then I always have my patients keep their body the same but turn their face as far as they can and smile. That'll give me an idea of their head tilt, and if this angle changes even more from the horizontal. Gives me some ideas about their upper cervical functioning. It also gives me ideas right to left side, how far she can turn, and then what her smile looks like. So this is a patient that has an appliance to try to maintain space in her. This is her basically her permanent retainer, and this is what she's using for her to control her closing. So this keeps her teeth apart a little bit and also creates space in the TM joint. So one of the things that we can do is look at cephalometrics, so where we actually measure forward head posture. And I am going to do a second video for this, so I'm going to stop this one here and then we'll add a second video.